Okay, if you're still working, please feel free to keep working. We're just gonna get started. So I just wanted to, first, I'll start by giving a shameless Maryland Patient Safety Center plug. In your folders, you have a flyer. This is all of the upcoming events for our perinatal patient safety specific focus. We actually this year, if you haven't heard, we have three kind of specialty area focus and then one general patient safety focus. So we are keeping our great focus on perinatal patient safety. If you are a member, and if you don't know if you're a member, please come up and chat with me, of the Maryland Patient Safety Center. You have access to all of these resources for free. So a couple things, on the front, you'll see our perinatal patient safety learning series. They are webinars. I think most of you have probably been to those, but we're gonna keep that going this year. They're monthly, 1 hour, 12 to 1 o'clock virtual. So encourage your team to attend them. If they're available, you can hang this on your unit, QR code. But a couple other things I just want to bring your attention to that are new this year. One is our perinatal specific patient safety tools. So coming up December, we're going to have reviewing safety events in the perinatal setting. So it's going to be a 2-hour course on how to review an event. We'll give best practices, and then we're going to do like an actual review with a case study. And so it will teach folks how to do that. So this is not RCA. This is how to review events that, you know, obviously that are coming through in your safety event reporting systems that might not make it to the level of RCA Sentinel event, but you need your review nonetheless. And so help to kind of level up teams in doing that and give some resources there. And then in February, we're going to have FMEA to proactively address safety in perinatal settings. So it'll be, again, very perinatal specific. And then we have safe tables. And so I'm not sure if all of you have been to a safe table before or not. I know some of you have, but a safe table is an in-person event. It's 2 hours long. It's kind of through our PSO. So it's a confidential and protective space to talk through specific patient safety areas. So the two that we chose this year for perinatal are neonatal resuscitation, teamwork, communication, and handoffs after a reset. Which is a topic that I am super interested in. And in May, we're going to do oxytocin errors because that continues to lead the ISMP as an issue. That'll kind of also go into tachycephaly, which is a big topic. So you can register for any of those. Everything is virtual except for the safe tables, which are in person and here. And so we just, registration's online, to do it easily, and we encourage you all to attend. But we also have 2 new areas of focus I just want to bring your attention to. One is medication safety, and one is ED, safety in the emergency department. So if you have any friends in the emergency department or that do med safety work, please encourage them to take a look on our website. But there's also some crossover, kind of like Grey's Anatomy and Station 19, like crossover events where we're doing emergency department and perinatal, or med safety and perinatal. So some of we're showing how they cross over with each other. So check those out.
They're on the website as well.
They are on the website as well. Thank you. I love it. And if you have any questions or you have ideas for topics, please just email me. I would love to hear your ideas. Okay, so I'm going to get this day started talking about severe maternal events and trauma in the perinatal setting, and kind of where I am coming from with this. I am not an expert in trauma-informed care. But it started to really kind of make sense to me and put pieces together as I've been doing a couple different talks on this. So it started about, I don't know, maybe 1.5 years ago. The Maryland Patient Safety Center helps to support Hopkins in their administration of the RISE program. The RISE, if you haven't heard of RISE before, it's a peer support program. And so I gave a presentation to all of the RISE professionals about severe maternal events, because I was like, you know what, I can remember, and I'm sure all of you have these events in your brain where it happened. I mean, I can think of one that stays with me 20 some years later, where this event happened and it's extremely traumatic. And it's kind of baked into your head. And I'm not sure that there was any specific, I know there was no specific follow-up for me, but I still kind of carry that event. I remember the people's names, I remember the baby's name, I remember exactly what went on. And so it made me think, hey, I want to talk to these RISE folks and ask them, hey, are you connecting with perinatal people? Do they call you ever? And it was really interesting because, I was talking to them and they're like, yeah, they were not perinatal people at all. They were just like the RISE designee for their hospital, and they came from across the country. And they're like, yeah, they don't call us a lot. And I'm like, I know they don't call a lot, because you know why? Perinatal people, I say, we're like an island, we're like a tropical island is what I say. Like, everyone looks at us and says, oh, that island over there, it's so cute. There's sunshine, there's rainbows happening over there, and then a storm hits, a massive hurricane hits the island, and it beats up the island. And so the islanders take care of it because they live on the island and they know what it's like, and this is part of their day-to-day, and they just kind of get used to being beat up by these storms that come in and kind of dealing with it, and we're tough, and we're the only ones who know how to live on our island. And then the people who, there's some resources, and this counts for a lot of things, but they're on the mainland, and they're looking over, they're kind of waving. And they'd be willing to help, but they'd have to row out there, and it's a little bit different out there in the island. And so I started to think about that and just think about how this impacts the care we provide. And then kind of next thing was, I have, many of you know, I have 3 children, 2 daughters, both which are nurses. My oldest one is working as a nurse currently. My middle one is in nursing school. And so my oldest one now has been a nurse for 2 years. And so she was going through this, the new grad transition to nursing, and she is not in a labor and delivery setting. I don't think that's her thing, but my middle one, I might get, but she was in an ICU, and there were some traumatic things that happened, and I could see how she was processing them. Now her unit reacted amazingly in supporting her. But we talked a lot about it, and her manager was great, called her in the next day. I was like, I know that was a lot, and what do you need help? Do you need support? And she was like, I talked through it with my mom. But most people don't have a mom who has a background and is able to say, yeah, hey, this has happened to me a bunch of times. This isn't you, this is normal, process this, keep talking about it. And, so I started to think about what are the implications of this on our workforce? So then insert the trauma-informed care workshop that we did in January. And that was really focused on teaching us how to be trauma-informed to our patients, which we've all been talking about that for a while now. How do we, how are we trauma-informed around patients who have substance use disorder or other conditions? And so I've been thinking about that. And as all of this is kind of coming together, I started to really think about, okay, what are the implications for all of this for quality and safety? So enter this presentation and where we hope to go with this. So follow along with me and see if it comes together for you the same way as it came together for me. So here's what the outsiders think we do in labor and delivery. That we're just rocking babies and bathing their head, and actually some new nurses think that too, because my daughter did her rotation. She's like, I love to wash the babies. I got to wash their hair. And that's, that you do love that. You get to do it, yeah, but it's not our main job, and it is kind of cute, but that we're just smiling and always just happy, and that's all that happens in that little island. But we know the current state of maternal health. So I'm not going to tell you anything you don't know. So we know that, maternal mortality has been increasing. Yes, there has been a little bit of a decrease, but it's still extremely elevated. So when we say that, I kind of get a little bristly when it's like, oh yeah, it's decreased. Well, yeah, we had a COVID influx. It's still not really decreased. We have the worst maternal mortality rate in all industrialized countries. There's significant disparities. Black women are dying, at 3 times the rate as white women. We know patient acuity. I won't even, I don't need to reinforce that to you, but this was from the Surgeon General's report, and this is from 2020, and talking about the percentage of chronic hypertension that is among childbearing age women, as well as increases in diabetes, the prevalence of obesity, and substance use disorder. So we you know that in your day-to-day practice. And then outside of mortality, we have severe maternal morbidity. So this is showing rates of severe maternal morbidity. They've been increasing exponentially over the past several years. So all of that is things that you know. So we're not just rocking babies and washing heads and smiling. Yes, we do smile and we do those things, but this is all going on around us as well. This is just showing Maryland. Maryland kind of sits in the middle of terms of all the states where ranking of severe maternal morbidity. So we're definitely not doing great, and can do much better. And our rates of severe maternal morbidity here in Maryland have been increasing, as well as the disparities. In addition to our maternal complications, we know that stillbirth complicates about 21,000 births across the US every year. So not only do we have these complications that are impacting moms, but we know that there's complications impacting our babies as well. And outside of stillbirth, we know extreme prematurity. So I'm not at all discounting the stress that our NICU colleagues have to deal with as well, managing premature babies and caring for neonatal death. So again, with neonatal deaths happens in about 4 in 1,000 babies. It's less than 1%, but still a common cause of neonatal death is premature birth, low birth weight, and birth defects, all which are stressful for our teams as well. And then outside of all of that, there's obstetric litigation, which I, working on cases and supporting, cases, it's so stressful for the physicians, the nurses, the teams involved. It's one of those things where obviously we're all healthcare providers and nobody goes into this to harm anyone. And then, the case pops up how many years later, 2 years, 3 years, 4 years, who knows how many more years later. And this is just another layer of stress. And how are we supporting nurses and providers that are going through obstetric litigation? Are we supporting them? How do we prepare them? I mean, this has come up as a topic in some of the teams that I've been around, like, do we prepare nurses and providers enough mentally for what's going to happen? And do we support them during this? So again, 80 to 90% of OBGYNs report being sued during their career. 50% of OBGYNs in the US report being burned out, and that litigation stress has been linked to depression or even suicide among providers. And obstetric-related claims are the 5th largest category of medical professional liability claims and the 4th highest category of indemnity payments. So this is a whole kind of piece that is weighing heavy also, in addition to the events that are going on. So I knew all of that. And I know you all knew all of that too. Didn't tell you anything new yet. And so I started thinking, like, how is all of this impacting nurses and providers in this space? So any good PhD, where do they go? Do they go to PubMed? So I went to PubMed. So I did a little search, and here is what I found. So in this article, they did a study of several hundred OBGYN nurses and found that significant levels of emotional trauma were present. Not surprising. Approximately 64% of nurses reported being involved in an adverse outcome in OBGYN. And of those same nurses, 92% reported experiencing 1 to 5 adverse events in their career. And nearly half of the nurses surveyed by resources reported that during their career, they had experienced the feeling of secondary victim trauma. So another study, this was a smaller one by Kruper et al. 95% reported involvement with adverse medical events. So the theme here is everybody's been involved. This is touching everybody. 75% had symptoms of traumatic stress. And those symptoms were anxiety, guilt, disrupted sleep in this study, using different services based on the symptoms, but the services they were using, Friends was the most common one. And so if you think about your own self, like, I remember me, who did I call on my way home? I had a friend that also was a labor and delivery nurse, and it was like debrief time, driving home. So Friends, peer-to-peer support, so other colleagues on their units, and then sometimes debriefing if they had guilt. In another study, again, this was labor and delivery nurses, 35% of respondents met symptom severity scores associated with secondary traumatic stress scale. So this is your colleagues. These are people that are working for you. they have, they're, being surveyed and it's bubbling up that they actually have secondary traumatic stress, post-traumatic stress disorder. You'll see that coming through. 84% of respondents reported witnessing a traumatic birth, and after witnessing a traumatic birth, responded to coworkers, families, and friends. So we haven't heard any kind of institutional resources being listed yet. We haven't heard managers come up or, any of those, or we're going home and we're just talking to our husbands, our friends, and our mothers about this, who are like, whoa, my husband doesn't say anything. He's just like, whoa, that sounds bad. Now he thinks everything is bad in everything. I'm like, that's not really true. I just have like a distorted view. So in another study, 37.2% of maternity nurses midwives met the criteria for post-traumatic stress disorder. So actually for post-traumatic stress disorder, think about that, like 40% of your team meets this criteria. A positive correlation was found between post-traumatic stress total score and the number of years in the profession, the number of traumatizing events, quality of their work life, burnout symptoms, compassion fatigue, post-traumatic cognition, and negative cognition about the world and negative cognition about self. So I bring this up because thinking about like the more those that have maybe been in the profession longer are experiencing more traumatic events, we might not be thinking that they need that much support because, hey, they're used to this. One of the MFMs I work with, when he's talking about nurses, he's like the battle-hardened nurses, like we've been through battle. We think we should be tough, but it's weighing on us. Talking about the NICU, this is really interesting to me, and I don't know if Kaylee's going to touch on this today, but there are some resources in here. They looked at NICU and neonatal care providers, but I think this translates also to physicians, OBGYN physicians, receive limited training on how to communicate bad news. So I have to now tell you, like, maybe I'm an OBGYN and I have to tell you that, your baby has died, or a bad news about the baby, or, tell the family some bad news about what has just happened to the mom. Most providers, nurses haven't really received training on how to do that and how to do that effectively. And so that really is hard. I mean, I'm sure you all have had to do that before in your life, but when you walk in there and you have to tell someone something that is not, is probably the worst news they've ever heard in their life, that impacts you too. So how do we do that in a way that is best? And so in this study, they felt that communicating a baby's death and informing on autopsy results was also traumatic to them as a provider, not just obviously traumatic to the parents, but to them. And the majority of healthcare providers showed some degree of post-traumatic stress symptoms. 34% had medium and 35% had severe post-traumatic stress. Professionals who got training on bereavement care and communication had less probability of developing those stress symptoms. So, I mean, I just want you to, at this point in this presentation, to just be thinking in your head, like, do you think your team has received, training on how to communicate things that aren't going so well to the patients? Like, thinking about your team, do you think these study results are reflective of maybe the stress that your team is carrying around? Have we ever asked? That was another thing, like, have we ever really done this and surveyed this in our own team? Midwives and labor and delivery nurses express powerlessness in advocating for women on many occasions. So this comes up sometimes where this disconnect between nurses want to advocate for something, but feel like they can't get to where they want to be, and so feel powerless, and that kind of is an implication for more stress. Healthcare providers had feelings of guilt and self-blame over adverse events, and there was inadequate support from their colleagues and organizations, which influenced their ability to cope with the aftermath of trauma and their decision to stay in the profession. So thinking like, I just did this project, Birth Equity. Some of you guys may have heard of it. And that one thing I noticed that dramatically impacted our ability to implement that program was the amount of turnover. And I hear that from so many of you, so I don't know if it's happening on all of your units, but turnover feels to me to be at like a high point. And, I'm also working in this perinatal and neonatal quality and safety fellowship. And so all of the fellows are doing these quality and safety projects. And overwhelmingly, the amount of turnover dramatically impacts our ability to do quality and safety work. And so again, I started thinking, well, why everybody's like, this is mass exodus is happening. And I'm not saying that today's presentation is gonna be this one size fits all approach, it's gonna fix everything. But I mean, it's just a different way of thinking about this. How are we addressing this? Because when, sometimes if I come into an organization after a traumatic event, and I might be coming in more to like assess workflows or say, hey, what might we be able to develop to make this situation safer? Many of the people who were involved in that event are gone. They're not there, so I can't even talk to them because they are just like, that hit me so deep that I can't even do this anymore. And we don't want that to happen because we know we want this to be a just culture. We know that it's typically 99.9% of the time, it was no one, like, no bad player in it. It was just, you know, a failure of the system, and that's safety, right? Like, how do we improve the system? So this, again, this just made me think, this is all like fundamentally linked. But if we could target and support these nurses and providers after these events in a more efficient and effective way, do we have the potential to keep that attrition from happening? So there's this scoping review on the impact of severe prenatal events on maternity care providers. And I put this up there just because I wanted to read you actually what their conclusion was. This is a 2024 study. And so it says the impact of traumatic perinatal events on maternity care providers range from severe negative responses where care providers moved positions or resigned from their employment in maternity care to responses where they felt they became a better clinician. So I don't want this to like be like, oh my gosh, all these horrible things are happening and there's nothing we can do about it, or it's all bad, because there is this potential to take those things that happen and use them towards good, to have this post-traumatic growth. And Maggie and Tara might get into that a little bit more, but to grow from them. But it's all in how I think we respond as leaders and help these folks move through them that can really help with that. So, however, a substantial number appeared to be negatively affected by traumatic events without getting adequate support. It really feels like there's this chasm that occurs after these events that we're not necessarily connected between the support we need. We might not know we need it. And again, as leaders, you are in no way meant to be therapists, and that we will say that over and over again. This is not to make you therapists. That's not what this is about. This is about making sure that we have systems that connect people with resources that may already exist, or do we need to work within our organizations to put some better systems in place? So given the shortage of maternity staff and importance of a sustainable workforce for effective maternity care, the impact of traumatic perinatal events requires serious consideration in maintaining their well-being and positive engagement when conducting their profession. Future research should explore which maternity care providers are most at risk for the impact of traumatic events and which interventions can contribute to prevention. So anyway, you know, that's again, the thing that really got me. This is a piece of that puzzle of what is, you know, contributing to the shortage and the attrition is the traumatic nature of our work. So the events that were listed as traumatic or contributing to trauma in all of those studies were things, and you guys aren't gonna think any of this is shocking. Maternal or neonatal death, stillbirth, or fetal loss. And that really, you know, made me think, because these are things that we do, I mean, I don't want to say on a regular basis, but a fairly regular basis. And so, and we didn't do anything wrong in those situations 99.999% of the time. But, you know, when you start thinking about it, if you went to other professions and you're like, I'm going to take care of a baby that has died, I'm going to dress it, I'm going to, you know, care for it, I'm going to keep it in the room. Other specialties would not be able to probably fathom that. And so, but we do it as our regular work. And so one, thinking about our new to practice clinicians, are they really prepared? Has there been some anticipatory guidance to them about this is what's coming? Because we know orienting new nurses is a big lift. And so we need to make sure that we're preparing them to be able to handle these traumatic events, because we're not going to eliminate, even if we go safety all out, which I'm all for, we hopefully can reduce some of those preventable ones, but we are not going to eliminate all traumatic events from our specialty. Hemorrhage, abortion care, events involving a difficult delivery like a shoulder dystocia, sudden and unpredictable events. Well, this sounds like every single event in labor and delivery. Perceived preventability, acute sensory experiences. And that was interesting to me too, because I think that means like someone screaming, like, you know, I have some like, remember of someone screaming, like a patient that came in and her baby had died and she was told, and I just had this scream, like it's a different scream. And it's just like back there in my head. High emotionality. So this could be anger, this could be tearfulness, and we know that there is a high level of emotionality that happens around all of these events. So again, how our staff then leave that room and are able to continue working in a safe way, and also what impact this has on them long-term. So how they feel, so this is what, again, in all that research kind of put together what they say. Negative emotions, a lot of anxiety, disrupted sleep, loss in their self-confidence. So, you know, when they're coming to work the next time, second guessing everything they're doing, you know, is that going to happen again if I do this, if I do that? Responsibility and regret. Impact on the practice and care was around patient safety, decision-making, teamwork, and capacity for empathy. Some more things, challenging their professional identity. Should I just leave? You know, like something bad happened, you're like, well, maybe I'm just not meant, I'm not cut out for this. Like, this is not for me. Guilt, insecurity, perceptions of insecurity regarding the organizational systems and managers. So when those events come, it really, you know, I think also puts our leaders to the test, because they're looking for someone, they're looking for something to support them after those events. And so there's more perceptions that around our leadership there. And loneliness. The quote of one of the folks in one of the research was, I was left alone with the emotional surge. So they didn't really feel like they had anyone to talk to. So what's been talked about before related to this? There have been some things done related to this. So you may have seen this patient safety bundle. It's actually not up anymore. It's an older one, kind of was retired. Word on the street is there is some work from AIM around this, but this was the patient, family, and staff support after a severe maternal event patient safety bundle. And so this had a couple call outs in it that I think are still valuable and some things we should think about. So multidisciplinary teams should work together to customize a workable and feasible protocol. So meaning how to support each other. So what is workable? When a severe event happens, what should we do after it to actually support each other? Have clear guidelines on when and how to activate it. So again, think about your team in the current state. Do you have that, and does this actually work? Educate all team members, nurses, physicians, anyone about the existence of peer report support resources. So if you have RISE at your hospital, which many of you may already have, do all of your team know about it? Do they use it? And do you talk about it regularly in, you know, staff meetings, etc.? And so that education can occur through department meetings, professional conferences, morbidity and mortality reviews. You know, that's a perfect time to continually reinforce what's the process for us to get people to the support they need. And birth facility leaders should actively monitor the mental and emotional status of individuals who are involved in a severe maternal event. And actually in this safety bundle, they called out using the Breslow post-traumatic stress disorder screening tool. And this kind of blew my mind a little bit, because imagine if you actually knew the level of post-traumatic stress of your whole team. Would that change how you interact with some of them? I mean, if it was obviously this would be an anonymous survey, but, you know, understanding like from that research that we just looked at, that 30 to 40% of teams have post-traumatic stress disorder, that's a lot. And to think they're functioning day to day in more stressful situations that we're kind of putting on top of them, does that change at all as leaders, how we think about things? So that was kind of what brought me to this space. And what implication, if you're functioning from a place of stress, which we all are, have some stress. I'm not saying we're all stress-free, but if we are functioning from that place and we're taking care of other patients, how does that anxiety and that stress impact our ability to provide safe and quality patient care and our interest in staying in this job in the first place? So what can we do? Some things, we can build capacity among staff to recognize signs of acute stress disorder in themselves and in their colleagues. And that I thought was a low hanging fruit, like, we just have to teach each other what we're looking for. What signs are we looking for in each other? Teach ourselves to be really like conscious of our own stress. But then it puts the hard place as us as leaders. What do we do when someone comes to us and says, I'm having this stress? Like, we can't shut the unit down. You can't be like, sorry, today's the day we just all shut down for a mental health break. That would be great, but it's probably not feasible, right? So we have to think through what's real, like what's possible for us. I don't know the answer to that right now. I don't know the answer, but that's what we're here to talk about. Establish a culture of debriefs, and you may have gotten the picture, but at the end of this, we're going to invite you all to be part of a debriefing initiative, and not patient debriefing. This is debriefing for quality, for safety, for debriefing each other to ensure that we can create workflows on our units that are feasible, and they're not going to be prescriptive. I'm not going to prescribe a workflow to anyone, but they actually can be effective, because I feel like when I am out and talking to people about like debriefing, we know the Joint Commission tells us we're supposed to do it, and it's on there, and we're like, yeah, we debrief. Yeah. Then I'm like, okay, well, tell me about your process. It's a little shaky. It's a little shaky. And then even when we do try to debrief, have the people really been, who are leading the debriefs, have they actually been trained in debriefing, which is a complete skill. I mean, if any of you have done like debriefs before, it's not super easy. So that's what we hope, that from this, that, we'll talk more at the end, what we're offering up, that you all may be interested in engaging some of your team in learning really how to debrief and creating workflows at your hospital to effectively embed this and make clear connections to staff support. And then mostly just an area of review of severe maternal events. If you're in MD Mom, you're doing this, and hopefully through that, there's also ways to follow up and connect. So they say they want the services. That's what the study said, that, a Slate article in 2020 reported that 91% of their sample, 839 obstetric physicians, wanted an institutional system of care. So they wanted to be able to connect. Their choice if they want to go or not, but you should have it. It should be clear. It should be easy to get to, and it should meet their needs. It doesn't have to be that everybody decides to go, for every event, but it has to be available to them, or should be available to them. So these were the other interventions. Team and peer support are essential. Colleague versus institutional support. So a lot of the research said that they loved colleague to colleague support. Like, just, do their peers know how to support them? Do they come to them, ask them how they're doing, check in after these events? Is that deliberate? It might just happen naturally, but we probably need some level of intention with that. So they like those conversations with peers. Screening for trauma. So how do we really understand what trauma our staff is living with? Psychological education. So prepare maternity nurses, midwives, and providers for exposure. So I don't know if any of you are in the education, the perinatal education collaborative for nurses, or, work with that, but that's something to consider. Like, how are we preparing new nurses and our residents for this? What's going to happen, but how are we giving that anticipatory guidance about that it's going to happen, and then what do we do after it? And training on how to communicate bad news, which, we're going to talk a little bit about the AFE Foundation, and they have amazing resources on effectively communicating with your patients. And you actually have a QR code in there, but I won't let Kaylee talk about that more. I won't give away her great stuff. Structured case conferences for emotional debriefing, and again, need some training in that. Safety and transparency for group processing, professional group sharing, end of shift meetings, team bonding sessions. So that was just the beautiful island that I think labor and delivery is. I think we are this tropical island that sits out there that seems like elusive and very cool. But we like to stay on that island too. Every time, we think we do very unique work. Nobody ever wants to come up to us, you know, the emergency department is like, stay, you keep your pregnant people up there, we're down here. But we know that when that hurricane hits, it's rough. So there are a lot of barriers, to implementing support. There's limited connections between peer support and EAP to labor and delivery. We like to go it alone. There's actually a low level of participation and support. So some of this is on us. I mean, like some of it is on us and we have to own that. But what I would say as leaders, we need to normalize that it's okay to ask for support, that it actually might be beneficial for you and why it might be beneficial, and make it easy to get to, and then make that support actually be like worthwhile. Because I've heard that feedback, and I'm sure Tara and Kaylee might share more about like the feedback that they've gotten when people have tried to access support, and like the person doing the support isn't really familiar with what we do, you know, because we're unusual. Awareness, and some of your team, if you surveyed your team, they might not even be aware. You could have an amazing program of support with all kinds of free apps and business, and they might have no idea, because we know how they do reading email. So that they might not have any idea that the services even exist. And normalization after the adverse event, that you're going to feel a way, and it might not be right away. You might still have that adrenaline, and you're like, oh, okay, I'm going. But then later, when you're laying in bed that night and you're like, what the heck just happened there? You have time to process that it's okay and what they should do and how they can connect. And there's limited structured debriefing. You know, a lot of the debriefings I see, it's like, we good? We all good? We're good. That one's good as it could. Okay, next to work. So we need to make sure that we have some training and some structure around that. So, you know, these are just some initial reflections for us to think about, you know, does your hospital, does your unit have a great connection with peer support services or employee health services or whatever your hospital calls them? If you went into your team tomorrow and said, out on the unit, and you walk around and you said, hey, everybody, can you tell me how to get to what do you do if you need support? Would they all say, I press this button on like the internet and I go here, and would they be able to say that to us? Do you have a predefined list of serious maternal or neonatal events that your team, that you know, or someone on your team knows that they should follow up with after? So like if there is a severe hemorrhage, patient transferred to the ICU, do you have like this list that say, I don't know, your assistant nurse manager reaches out to everybody that was involved in that, just say checking in, seeing how you're doing. You need anything from me? Do you share support resources during your debrief? So if you're doing a great job debriefing already, during that debrief, do you, one, ensure that it's psychologically safe during the debrief so everybody can speak up? And two, at the end of it, do you say, hey, listen, I want to make sure everybody on this team who's in this debrief is aware that we have these resources. This is how you access them. If you a week, a month, or whenever later decide you need support. As leaders, you actively reach out to your team after SMM, and do you provide education on the importance? So level set, again, that's this just like, have we even said to our team, it's okay. It's okay, it's normal, this happens, this is that anticipatory guidance, especially for our newer team members. And, you know, remind them that it's normal to have these feelings. We all experience it at one time or another. So here's where the trauma-informed care comes in. This is where like my mind was blown a little bit. So again, talking about trauma-informed care up to the patient. We've been talking about that for years now, doing education about how we can be more trauma-informed for our patients. And so in all of this, I've been learning more about trauma-informed care and the key tenets and how, and then I started thinking, wow, well, those tenets sound exactly like safety, like a safety culture. It's really interesting to me. So, you know, we know all these things. I'm not going to repeat them. Nurses and providers feel burnt out. They're frustrated. Their mental health is suffering. They're unsupported, you know, all of those things. So we're in a state of kind of some stress right now in healthcare, all of us. And what causes trauma in healthcare, right? Now, there's varying definitions, and my friends today will tell you some different definitions, but they're all basically the same. This is a definition from author et al. He defined trauma as experiences that overwhelm an individual's capacity to cope. And trauma responses can be triggered in the workplace based on emotional scars. So stressful professional experiences, increased workload, and you all may have trauma too. I'm not saying that this is just your staff. This is for all of us, right? A terrifying event. And that terrifying event could be an event that impacts us directly or indirectly, like happened maybe in the room next door and the whole staff is really impacted. And you may have had that happen before. One really serious event happens and everybody shook from it, right? There was trauma after the pandemic that's still ongoing, that folks are still working through. And then also being physically harmed or near harmed. And that's come up, I've been talking, again, I said, my daughters are nurses, and my one daughter had an incident with this where, a family member was like right up on her, and it scared her. She was not harmed, but he was in her face yelling at her. And again, how does that make you even think you want to go back to work the next day? So when you're thinking about trauma, also make sure that you're thinking about outside of just the actual event of the patient to some other things to contextualize it. So this impact of trauma on healthcare workers, again, outside of leaving the job, has impact on like physical signs and symptoms like headache, anxiety, depression, social isolation, leaving the job, or also impact on patient safety because they may feel uncomfortable doing things. They may not be able to remember things, maybe scared to go in a certain room that they had the situation happen in before. So lots of impact of trauma on healthcare workers directly. So what's trauma-informed care? Trauma-informed approach acknowledges that healthcare organizations and care teams need to have a complete picture of a person's life situation. So again, a trauma-informed approach is not just our approach to patients, but it's the organization's approach to its interactions with the people that work there as well as its approach to how it cares for patients. So it's both. So it needs to be implemented at a clinical level, but also an organizational level. And that's the part that I was like, well, that just kind of hit me there. I had to think about that one for a minute. Like, what does that really mean? Because I had not at all been really considering what that meant before, and the impact that meant for nurses and providers. So then I learned about trauma responsive leadership. So trauma responsive leadership is not about treating or diagnosing. So that's the thing that I want to be clear about. I'm not trying to say you're a therapist. I'm not trying to say you have to diagnose anyone with anything, but it does provide leaders with tools and strategies and skills to disrupt continuums of harm and to implement policies that can mitigate harmful effects of trauma and to foster an environment of psychological safety. And so it's both a style of leadership and a set of tools that support your leadership practice. So the way I think about this is that trauma responsive leadership is the foundation to building a safety culture. So that I'm like, oh, all these things need to be in place by like the leadership, the organization, in order for our nurses and providers to practice as safely as possible. Well, I'll show you. So here is kind of this, this idea of building a safety culture, okay? You have vision, you have trust and respect. So this is a safety culture. When I went online, I said, safety culture, image. This is what it said. Trust, respect, inclusion, board engagement, leadership development, adjust culture, and behavioral expectations. And we're focusing towards zero harm. So that's a safety culture blueprint for success. Okay, other things. Some of you maybe have done the SAQ, the Safety Attitudes Questionnaire. These are the components of the Safety Attitudes Questionnaire. Teamwork climate, safety climate, working conditions, stress recognition, perceptions of management, and communication. So again, these are the components of when you look up safety culture. So now let's overlay that with what trauma-informed care is, or trauma-responsive leadership. So the first part is there's 4 R's of trauma-informed care. Realize. So today, the idea is as leaders, we realize the widespread impact of trauma on our teams. So hopefully just by the end of that presentation this morning, you're like, okay, a lot of my team probably has some trauma just from work. In addition to, that's not talking about personal life, things like that. Recognize the signs and symptoms. So my friends are going to get in more deeply about like what are signs and symptoms of trauma in our staff, but we're hoping that by the time we leave here today, one, you're like, wow, that's a big impact on my staff if you didn't already realize it. But how do I recognize it in them? What are some things? And then we're gonna give you tools to respond. So how do you respond when you start to see these things in your staff? Or hopefully, how do we resist re-traumatization? Because we know that the majority of your staff at this point has been exposed to some trauma. Like that's just unfortunately, part of the job. But how do we resist re-traumatization? So this, again, sometimes when I think the quotes are really powerful, I put them in there, but a trauma-informed approach to leadership recognizes that leaders must not be focused solely on accomplishing work or managing people. Leaders must recognize trauma at the individual, group, and system level. They must not only intellectually understand trauma and its impact, but also be able to integrate theoretical knowledge into an active trauma-informed practice. Leaders must finally set up the conditions for people in their care to be safe from re-traumatization, which may require leaders to actively address and dismantle organizational patterns and structures that perpetuate trauma. So here are the guiding principles. Again, safety culture. This is the guiding principles of a trauma-informed approach. This is where my mind was kind of blown a little bit. 1, safety. That's the first guiding principle of trauma-informed approach. Trustworthiness and transparency, okay? Peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. So remember the safety culture one I showed that was like trust and communication and leadership. And then this is the trauma-informed care one. And I'm like, oh my gosh, they're like very overlapping. So then I started thinking, okay, we're trying to build a safety culture. So then leaders essentially need to be trauma responsive, need to be trauma informed to build a safety culture. So that's how this kind of came to be. So I put together, it's in your folder. And again, this is not for you to like answer, but for you to have, it's a self-reflection. And so this is kind of goes along with these slides that I have up here. So I believe that trauma responsive leaders are the foundation to the organization safety culture. And that's because I think those guiding tenets of trauma-informed care literally are almost identical to me to the safety culture pieces. And so I took those key principles of trauma-informed care and kind of laid them out and then put a couple bullets underneath of questions to kind of like ask yourself as you're reflecting on your leadership practice. Around each of them. And so when you look at each of them, safety. So safety isn't just keeping a workplace that's free of like workplace violence, but it's, are you creating, these are adapted also, I would give credit to the author. There were 2 articles that had some pieces of this and I kind of massaged them together to come up with that self-reflection. Create predictable, consistent experiences and spaces where people feel welcome and are clear on what's expected of them. I think that is really interesting, like clear on what, when they said that, I'm like, oh, that's something in jobs you always like. You like to know what's expected of you. Like, are you doing your job well? Trust and transparency is built when leaders are inclusive and follow through on what they commit to and are honest with their teams. I don't know if any of you in this room are on the Facebook page, Labor and Delivery Nurses Rock. Is anybody on there? Okay, if you're not on there, I highly recommend to join it. It's awesome from a clinical level. They have really cool, sometimes they talk about tracings. They had some pictures of cool placentas yesterday. But it also really gives you some interesting insight into what your teams are thinking. Posts are posted anonymously most of the time, but people respond and have lots of feelings about things. But then I started thinking, this is what they're saying. Like, one other day it was somebody posting about how she's been a nurse for a really long time and the charge nurse is giving her the worst assignments all the time and always giving the good assignments to their friends. And so, does that happen? Possibly, maybe, And so is that an inclusive environment? Is that building a predictable environment? Is that really a safe environment? Is that trauma informed? So these may seem like they're just like petty little things, but they're not building environments that are, then she said, I've been a nurse for a really long time. I think I'm just going to leave. I don't think I can keep working there. And so the work that we're talking about today and the things we're talking about today, obviously, you all are here, but this goes for our charge nurses, anyone who is in, leadership positions over people. It's important for them to consider, and especially obviously charge nurses, because they're managing all of that day. They're there when the severe events happen, and how this really has direct impact on the quality and safety and care we provided. Peer support, work with power and understanding that the impact of institutional hierarchical power impacts our ability to do good work. Like, then they talk about policies that are coming up, and some of these policies I can understand, but again, if you look at this Facebook page, they were talking about how now they were going to be required to wear all the same badge reels. And this was dramatic. This was very dramatic. I mean, this was like, hundreds of people replying. Yeah, it's very interesting to follow this, because it gives me lots of insight into what's happening. And that's why I feel like if you're not on there, I think it's really helpful, because it's like you get this backside of the door, like insight into how things that may not seem very important to you, but they all started talking about this was taking away their individuality, and and it made them feel a whole lot of way. If this was going to make your team feel this angry, there's a bad reel, maybe we just don't say you have mean bad reels. I don't know. But I think that these are just important things to understand about our team. Collaboration and mutuality, create environments where learning and curiosity can be explored without violence or judgment. That one I really loved, because that to me is the core tenet of safety culture. You can have a question. I always have lots of questions. I'm always like, well, why are we doing that? Or why are we doing that? I'm kind of like a 2-year-old. Why is that happening? But that is, we have to open ourselves to say that environment of questioning is what we want, so that we can push ourselves to create better workflows, better systems of care. And maybe we can't fix everything right now. That's okay. But having the dialogue and encouraging people to be able to speak up in a way that may be for patient safety is really important. Empowerment, voice, and choice. Explore how to return control, enable self-determination and choice to your team, and implement shared decision-making. You may have shared decision-making on your teams. You may have shared governance. Lots of, units have those type of things. Does your team really believe that it is shared? Do nurses and providers come to the table at the same place? Is the power differential leveled out when they're at the table? And how does that communication flow? Because again, we think about team steps. It's all about communication, right? It's all about communication between our nurses and providers. But if there's no empowerment on one side of the team, then team steps isn't going to work. They both have to feel like they can talk, and that there's not this tension or this rub. Cultural, historical, and gender issues, and this is creating an environment which support individual and cultural differences. And we know that that's super important to think about how inclusivity and we support diversity, and do we do that on our teams. So I gave you that leadership reflection. That's this. I am not asking anyone to self-reflect out loud, but I wanted to give this to you because I thought these questions were just really powerful in thinking through how this directly ties to the development of a safety culture on our unit. And so I hope that by the end of just my little presentation that you've realized the widespread impact of trauma on your staff, that you're going to start by the end of today to recognize the signs of trauma in your staff and have some tools to respond, and actually some words. Okay, sometimes we say things, we've talked about that as a group, that sometimes we're well-meaning in what we're saying, but how it comes out may not be interpreted that way on the other side. So we need to have some tools of how to respond that can be some things in our toolbox that we can use. And so these are the things that off the top we could do to help address that re-traumatization. So cultivate a culture of post-traumatic growth. So that just means, you know what? Bad things are going to happen on our unit. We cannot avoid all of them. We want to seek to eliminate all preventable errors. That's what we're driving towards. But we know that things are going to occur. So what happens after that? And we have to try to move it to something that positive happens, and that's by ensuring that people have resources and that we're addressing that and giving people some anticipatory guidance around labor and delivery, NICU settings, they're stressful, but here's some tools that you as a staff member can use to grow. As a leader, understand the trauma response, and we're gonna do some role play later. You'll get to see, we won't make you participate, I promise. You just have to participate as an audience. We won't make you be. And I know that was stressful for a minute. They were like, we're leaving. Where is that on the agenda? We're not doing any of that role play. So you need to understand that trauma response can look different for everyone. My kind of response is I have to talk. You didn't guess. I have to talk until I feel like I'm through it. So that may take me a day, it might take me a week. You've probably seen those Instagram reels, like, thanks for being that friend that let me talk about the same problem over and over again, and listen until I got through it. That's how I deal with it. Other people may be quiet. People may miss work. People, they might call out. Some people might drink or use other substances. So everybody has a different kind of trauma response. And so as leaders, we need to be aware of things that may not initially struck us as a trauma response. We might think crying is a trauma response, or, kind of falling to our knees or something like that. But everybody has a different one. And so are we aware of some behaviors that might be changing in our staff that actually could be trauma responses, and that could be impacting their work? Promoting open conversations and, not just being like, well, suck it up. We got this. Move on. I mean, that's kind of the environment I grew up in as a nurse, like put your big girl panties on and, just keep going. You got to go back in there. It's going to be fine. But really ensuring that we are promoting a space for people to share their feelings and that that's okay to do so. Strive to respond with compassion and empathy, create safe and respectful environments. And again, that was like, that's a safety thing. Safe and respectful environments. Doing that allows us to report safety issues. That was great. That was a win for me. Diminish that stigma associated with expressing emotions, be present and emotionally accessible. And this is a hard one for all of us. Model and inspire self-care. It's a struggle sometimes, I am like a worker. I actually like to work. Work for me is actually self-care because I feel like I can work through things, and not everybody is like that though. Some people need to be outside and, breathing the fresh air. So you all need self-care too. So whatever that is for you, make sure that you're doing it and showing your staff that it's okay to take care of yourself and you actually promote it. This was in one of the articles that I found, and I just thought this was helpful, and I can share this with you if anyone wants it. But they called it relational practices. So tools to practice trauma-informed leadership. And I thought this was interesting because it's the language. Maggie and I have had conversations around being in a situation where, a severe event happens, the event's over, the leader's present, the leader is there, the leader actually wants to provide support, but then they say things that might be perceived a little different way. So the example that Maggie had shared was a leader said something like a severe hemorrhage had happened and everybody the patient lived, was safe. The nurse was crying because it was very dramatic, and the leader said back, now, I don't expect you to be crying in your car on the way home. Now, that leader did not in any way mean anything by that, just was like, come on, you can get through this. But how that was perceived by the person that she said it to was like, it's not okay to show emotion, and so we are, I think, well-intentioned. I do not believe in any way that leader was trying to shut her down or shut her up or any of those things, but how it's perceived by our team. So some of the things that they call out here, they say, practicing human connection. If someone comes to you, start with saying things like, thank you for coming to me. I feel honored that you would share that with me. If they're telling you about emotion or telling you how they're feeling about something, that you don't have to say that it's right, that you agree with it, but you're happy that they would share it with you. And that is kind of level setting, that it's okay to talk about things that are emotional. If someone had a rough delivery or difficult experience, saying things like, it makes sense that you would feel that way. So you're validating, kind of how they're feeling. Wondering, like, so after an event, if you're checking in, like you probably do leader rounds, you're probably walking around your units a lot, checking in with people. If you know someone had a significant event, how are you really? What worries you? What's most important to you? What do you need? And you probably ask some of these things just intuitively or are doing it already, with your teams around just safety or just check-ins. But this is validating that those things are good. Following up on things, tell me more about, if you are reviewing an event, let's say a safety event came to you and you reviewed it, and now you're following up with the team, you give your summary, and then you can say, do I have this right? Because it's giving the team then the opportunity to give you feedback back. You're not claiming to know everything about what happened. What's most important to you right now? After an event and you're talking to someone, you need to figure out like, what are their priorities? Because they might still be kind of reeling from all of that. And then, kind of this last piece of holding space. How do you create a safe space for your team if they're coming and knocking on your door in the office and they're, their little head peeks in? I know that happens a lot to our nurse managers and physicians and says, you want to kind of tie it back to something else that they may have told you. I remember when you told me. So it shows that you actually know them, you're invested in them, and really thanking them for being open and vulnerable and reminding them that you're there for them. Even saying just, I'm here, so that they know that your door remains open and they can come back anytime to kind of check in with you. So if you guys like this list, I see some people taking pictures. I'm happy to send out the article to you so you can read the full article. And then this was a little figure that was in there, but I thought they were really great kind of points, because even if you just pick one and it's kind of something that you can start to embed, and then you can add another one, start to make this toolbox. So that was my portion. I hope that it started to connect the dots between why trauma responsive leadership is something that quality and safety has to do with, and that it's laid the foundation for my colleagues who are going to come up and talk much more about, trauma-informed care.